Parenteral nutrition, PN, is a life-saving intervention used to provide nutrition intravenously when oral or enteral feeding is not possible. While highly beneficial, it is associated with several complications that can affect various organ systems. These complications are broadly categorized into mechanical, infectious, metabolic, and hepatic complications. 1. Mechanical complications. These arise due to the insertion, maintenance, or removal of central venous catheters, CVCs, which are typically used for PN delivery. Catheter-related thrombosis. Formation of blood clots at or near the catheter site can impair blood flow and lead to serious complications like deep vein thrombosis, DVT, or pulmonary embolism. Catheter malposition. Misplacement of the catheter tip may result in inadequate delivery of PN or vascular injury. Pneumothorax. Accidental puncture of the lung during catheter insertion can cause air to accumulate in the pleural cavity. Hemothorax. Bleeding into the pleural cavity during catheter placement. Catheter occlusion. Blockage of the catheter due to blood clots, fibrin sheath formation, or precipitation of infused nutrients. 2. Infectious complications. Infections are one of the most common and serious complications of PN, often linked to the use of CVCs, catheter-related bloodstream infections, CRBSIs. These occur when pathogens colonize the catheter or infusate, leading to systemic infection. Common culprits include Staphylococcus aureus and Candida species. Sepsis, a life-threatening condition resulting from the body's response to a severe bloodstream infection. Local site infection, redness, swelling, or discharge at the catheter insertion site, which may progress to systemic infection if not managed promptly. 3. Metabolic complications. These arise due to the incorrect composition or administration of PN solutions. Hyperglycemia, elevated blood glucose levels due to excessive dextrose in the PN or impaired insulin response. Hypoglycemia occurs if PN is abruptly discontinued without tapering or due to insulin overadministration. Electrolyte imbalances, hypernatremia or hyponatremia, sodium imbalances, hypokalemia or hyperkalemia, potassium imbalances, hypophosphatemia, particularly common in refeeding syndrome, hypocalcemia or hypercalcemia, calcium level disturbances, magnesium imbalance, often linked to hypomagnesemia, refeeding syndrome, a potentially fatal shift in fluids and electrolytes that occurs when nutrition is reintroduced after a period of starvation. Metabolic acidosis or alkalosis, acid-base imbalances due to excessive or inadequate buffering components in PN. Number 4. Hepatic complications. Liver dysfunction is a common issue in patients receiving long-term PN. Steatosis, fatty liver, more common in adults, associated with overfeeding or excess carbohydrate administration. Cholestasis, impaired bile flow, more common in pediatric patients, leading to elevated bilirubin levels. Gallbladder sludge and gallstones result from bile stasis due to the lack of enteral feeding. Parenteral nutrition-associated liver disease encompasses a spectrum of liver abnormalities, including steatosis, cholestasis, and fibrosis. Risk factors include prolonged PN use, sepsis, and nutrient imbalances. 5. Other complications. Bone demineralization, metabolic bone disease. Long-term PN can lead to reduced bone density due to inadequate calcium, phosphate, or vitamin D intake. Micronutrient deficiencies or toxicities. Deficiencies, for instance, selenium, zinc, and copper deficiencies in prolonged PN. Toxicities. Excessive manganese or copper can lead to neurological and hepatic complications. Fluid overload or dehydration. Improper fluid management can lead to edema or volume depletion. Management and prevention. To minimize complications, the following strategies are recommended. Catheter care, strict aseptic technique during insertion and maintenance. Monitoring. Regular biochemical monitoring for glucose, electrolytes, liver function, and trace elements. Individualized PN formulation. Tailored PN composition to meet specific patient needs. Tapering. Gradual initiation and discontinuation of PN to avoid abrupt metabolic shifts. Enteral feeding. Transition to or combination with enteral nutrition whenever possible to reduce dependence on PN. Parenteral nutrition requires meticulous planning and monitoring to mitigate these risks and ensure patient safety. Early recognition and intervention in the event of complications can significantly improve outcomes.